being here. You have been making the rounds. I've been watching you out there, so I'm excited to add a little Jimmy Moore flair to it. I remember you and I talking at some conference. It might have been Low Carb Denver, Vail, whatever it was called at the time. But we had some really interesting kind of conversations about insulin resistance at the time. And little did I know you were working on a book someday about it called Get Sick. So Dr. Ben Bikman is his name, you guys. There is his brand new book, Why We Get Sick. I think it's probably the go-to book for people wanting to better understand insulin resistance. And we're going to be hearing a lot more about that thanks to people like yourself, not just doing the research, but highlighting the research. I love it on your Ben Bikman PhD over on Instagram. I love it when you post just a study and you're just like, hey, here's the evidence of a study that supports the kind of work that I talk about, and in an unbiased way, which is very refreshing and rare in this day and age of everybody's got an opinion.
Yeah, Jimmy. In fact, I was thinking as I was anticipating our meeting today, what's fun about this is that you were the very first podcast I ever did, ever, on your Live and La Vida Low Carb. That was the very first podcast ever. And it's fun that here we are again. Yeah, so insulin resistance is the thing I've really devoted my career to understanding, and it's relevant. My hope, my fear is that someone would hear the way you just described the book, which was perfectly accurate, like really to get everything the person needs to know about insulin resistance. And the average person would say, well, I don't need to know about insulin resistance. It doesn't have any bearing on me. Well, the reality, of course, is that it's the single most relevant. It's the single most relevant health problem we can imagine.
Your sound just changed. Can you get headphones off and see what the sound is like? Because it's really.
Sorry. Did it get better or worse?
It got worse.
Oh, okay.
Can you unplug it completely and listen through your computer system and see what that sounds like?
Here you go. That's better?
Yeah, there you go.
Okay, sorry. I noticed that it wasn't getting from my headphones, but maybe it doesn't want to this time. Maybe it's better.
The vegans don't want us to hear the message you're about to share, so keep going.
Yeah, sorry. So insulin resistance is really the single most common health disorder, certainly in the country and very likely in the world. So this is a problem that that people need to know about. That's why I wanted to write the book. I wanted them to know that insulin resistance is not some sideline disorder that people don't really have to worry about. It is very, very likely that most people listening to this have it. And it's something that due to our environment, due to our lifestyle, it has become, like I said, the single most common health problem. And it has its hand in so many other problems.
Can I tell you what the public relations kind of communications of trying to talk about insulin resistance, what the problem with it is people hear insulin and their brain automatically turns off because they don't have type 2 diabetes. And that's something I think we need to kind of end in people's brains, that having some kind of disturbance with the insulin pathway does not just manifest as type 2 diabetes. That's the worst manifestation, I suppose, of it. I guess type 1 would be even worse, but people walk around with this propensity of their pancreas not quite working the way it's supposed to work because of environmental factors, because of foods that they're eating, stress. There's all kinds of things that could impact it. So that's the public relations kind of marketing of all of this, is it's got the word insulin in it. And as soon as you say insulin, before you even get to resistance, brains are turned off and they apply to me.
That's exactly right. You're exactly right. People hear insulin and immediately think of it only in the context of its relationship to glucose, and thus only in the relationship with its context to diabetes. When the reality is, insulin does far more than just regulate blood glucose levels, which makes it far more relevant than just diabetes. Indeed, every cell in the body, every cell has insulin receptors. Insulin is going to tell those cells to do different things. It'll have a different effect or action at every one of these different cells. And why wouldn't it? Because they're all different. But the theme of insulin is to tell a cell to take in energy, store it, and make things from it, which is why we call insulin an anabolic hormone. It wants to tell the cell to take in the energy and store it or build. There are many, many other sort of effects related to that, like the effects that insulin would have on blood flow, expanding blood vessels to make them have better flow, for example. But regardless, in the case of insulin resistance, it touches on virtually every chronic disease, diseases of the brain, like migraines and Alzheimer's disease, diseases of fertility, polycystic ovarian syndrome in women, or erectile dysfunction in men, and many, many more. And that's kind of the middle part of the book.
Yeah.
It's basically highlighting, or the first part of the book is, what is insulin resistance and why does it matter? Going through all the diseases that come from it. And then the middle is, where does it come from? Once I've introduced the villain, we kind of go into the origin story. And then the last part of the book is the happy ending, which is you can fight it.
Here's how you fix it, right?
Yeah.
So one thing that's kind of disturbed me over the years, the more I've understood about insulin resistance and its connection to all those chronic diseases that you mentioned, is people see heart disease, they see type 2 diabetes, they see Alzheimer's, they see PCOS, they see IBS, they see all these manifestations of disease, and they're all classified in the medical community as different diseases. We have a whole section, a whole organization, the American Diabetes Association. We got a whole organization, American Heart Association, American Cancer Society. Then they're all the same disease. It's all insulin resistance. How can we get the message to patients, and I guess to an even greater degree to the medical professionals, to stop looking at this in the micro and look at the macro, realizing that they're all insulin resistance related?
Yeah, right, Jimmy, well said. It's the sooner we acknowledge that so many of these seemingly distinct problems have at their core a metabolic origin, then the better we will detect and treat the patients. And let's imagine, for example, like what you're alluding to, a patient has come in, and this is a woman who maybe has hypertension, diabetes, and polycystic ovarian syndrome. She could leave that doctor's office with 3 distinct medications, and that would be the conventional treatment. Here's a treatment for each of these things, little realizing that each of those is profoundly connected to one root cause, insulin resistance. So rather than pruning the branches off this disease tree, go right to the core, go right to the trunk or the root of the problem. And if we acknowledge that all of those disorders and more has insulin resistance as a common cause, then we would say, well, how can we best improve the insulin resistance? And to my great delight, it is not a drug problem. You could take the best, most insulin sensitizing drug in the world, and that is metformin. For a good reason, it is the most common anti-diabetic drug or insulin sensitizing drug. It works pretty well. Like every drug, it has side effects. But even that best of all drugs pales in comparison to the benefits that can come from lifestyle changes. Lifestyle change has been shown to be at least twice as effective as metformin has. So once you acknowledge the common cause behind so many of these diseases, you then hopefully take the next step and acknowledge that this is a lifestyle problem. The life we live, the diet we eat is the culprit or the cure. Well, let's make it work for us.
So let's get into some of that lifestyle stuff, because the obvious one is the diet. And I definitely want to come back to that one here in a minute. But what are some of the non-diet things? I don't think we give enough highlighting and credence to things like chronic stress that's unresolved, childhood trauma and other sources of adverse childhood events and things like that kind of impact people's metabolism, which I guess indirectly then makes them eat more to cover up pain from trauma, and that kind of is a self-fulfilling prophecy there. But what are those other things besides diet? I definitely want to get into diet here in a minute, that can impact your insulin resistance. This is something I'm not hearing a lot of people talk about, Ben.
Yeah. In fact, Jimmy, let's kind of go with the first thing. You prompted a thought in me mentioning stress. Yes, without a doubt, stress, whether it's a physical stress or an emotional, psychological stress, they both will result in an increase in the stress hormones, cortisol and epinephrine. Those are two very powerful insulin antagonists. They're directly combating what insulin's trying to do, thus directly causing insulin resistance. And we can detect this very, very quickly. You can put someone on a drug medication that acts like cortisol does, like cortisone or prednisone or dexamethasone, and they will become very, very quickly very insulin resistant. So this is not a subtle effect. It can be quite powerful. Now, you mentioning birth and trauma, one of the interesting things about humans is that we are born and we're supposed to be chubby. It's healthy. It's a natural state for humans. And it likely actually is a state that is meant to help feed our brains, because we're the only land-based mammals that are born both chubby and with brains that are bigger than the birth canal, much to mother's dismay. And the thought is that a lot of that extra chub on the baby gets metabolized to ketones to feed the brain. And indeed, a newborn is in ketosis, 2 hours deep, like 2 millimolar ketosis within just 2 hours after eating. So it's very quick. But nevertheless, my point, a baby that is born underweight or a baby that is born too big will both have metabolic complications. And that might seem, if a baby is born too big, it might seem obvious. You'd say, oh, well, yeah, of course. Mom was just gestational diabetic. She was hyperinsulinemic. Baby just got bigger than it should. And now baby has more fat cells, and baby might have to fight with that the rest of its life. That's possible. On the opposite end, it's extremely compelling that if a baby is born premature or underweight, but emphasis on premature babies that don't have time to lay down that big layer of chub, that is a kid who will be born underweight. Within a few years will catch up to his peers. Then a few more years will have passed them. It's like the body that baby is born in such a state of like almost panicked preservation to store whatever energy it can, that the baby metabolically is going to be fighting this battle, that it's going to be much harder for that kid. And I highlight that in the book, where if baby is born too skinny, that is a baby who's likely going to pass and have metabolic complications like obesity and diabetes later in life.
And autoimmune disease as well.
Oh, many. Yeah, that's right. Many problems, including potentially cognitive problems, because baby didn't have enough fat to make ketones to feed baby's brain.
And that impacts mental health.
Oh, yes, that's right. Yeah, it's disastrous and just one of the tragedies. So stress in many of its forms, inflammation, if someone has an autoimmune disease, which you just mentioned, you can actually track insulin sensitivity status changes based on the status of the autoimmunity. This has been done in diseases like rheumatoid arthritis. Like most autoimmune problems, rheumatoid arthritis can ebb and flow. It can have an active phase and then a kind of subdued phase where the joints are really hurting or the joints are fine. You can measure the insulin resistance, and as the person gets into an active phase, so really inflamed and painful, insulin resistance climbs up. As the active phase subsides, then so too does the insulin resistance. So inflammation also is a key cause of insulin resistance. And I highlight those because those are the non-dietary origins. But then as we start to shift the focus on diet itself, then those can still be kind of relevant, but then it really gets to hyperinsulinemia.
Well, and what's raising the inflammation? I definitely want to get into that with the diet in a minute. One more non-diet thing. We know from several studies that even like one night of bad can actually make you metabolically, clinically insulin resistant. In one day, one bad night of sleep. I know. Yeah.
So
then they go, well, wait a minute, what? But that's how profound sleep is. So talk about that research.
Yeah. Thanks for stopping me. In fact, I usually like to bring the sleep in when I talk about stress, and I just overlooked it because it is related to those same stress hormones.
I'm here.
Yeah, no, I love that you stopped me because appropriately. So sleep deprivation, like you said, and I cite these studies, even one bad night, the person will be demonstrably less insulin sensitive the next day. So it's a real phenomenon. Now, the person shouldn't look at that and be so discouraged. and think, oh, well, great, one bad night, I'm host. Well, one bad night can be undone with one good night,
Right.
So it's not like this becomes a truly pathological setting. But you can see in today's world of obsession with cell phones, we just can't get off our phones, or we're eating too late into the night and we just aren't sleeping well. That starts to all feed into the formula causing insulin resistance. Yeah, but without a doubt, that stress encompasses sleep deprivation, because if you slept poorly, your cortisol levels will be higher that following day. That stress hormone is up.
It's taken me years to entrain my circadian rhythm and to get my sleep down, but now I measure it with the Oura Ring. And every single day on Instagram, I'm posting my data. I think this morning was a sleep score of 92, and I had over 2 hours each of REM and deep. So when you dial it in, you at least remove that aspect of what could be causing the exacerbation of insulin resistance.
Yeah, I totally agree. In fact, I use an Oura Ring as well. I don't wear it during the day because it's just too cumbersome. But my score last night.
Get the titanium one. You barely feel it.
Yeah, I couldn't afford it. I'm a professor. I can't afford that, Jimmy. So it was
books today, guys.
I know. Yeah.
Why we get sick.
Yeah, everyone, help me upgrade my ring and go buy my book. Yeah.
We're gonna go fund me for Dr. Bikman for ring.
Yeah, so my sleep score was, I think, 86, which for me is very good.
Very good.
I will say the single most relevant aspect of what will dictate, or the most prominent item that will dictate whether my sleep is good or bad, it's whether I go to bed stuffed or not. So if I just have to know, I eat my last food at around 6 o'clock. I go to bed around 10. If I eat later than that and I go to bed with a stuffed stomach, the Oura Ring is so smart. And that's what really first helped me identify these kind of bad habits I was getting into, eating too much in the evening, because my heart rate would stay too high, my body temperature would stay too high, and it will say, "Did you eat too much?" And I would think, you know what? I really did. I really did.
It's so funny you mentioned that, because I noticed the same thing. My heart rate variability would be way off early in the night. I would have trouble getting into a deep state of sleep early in the night, which is when you usually get your deep. Yeah, I noticed the same thing. And ever since then, I titrate down. And of course, I have a little more flexibility in my schedule than you do, but I titrate down my eating till about 4 to 5 o'clock is when I try to eat that last meal. Then I'm an early to bed guy. I'm in bed by 8 o'clock. So it's right at that kind of 4-ish hours, 5 hours like you do. But yeah, it makes all the difference in the world. And also not drinking as much towards the latter part of the day. So you're not getting up and down and up and down to go to the bathroom. It is amazing, all of these little biohacking things that are accurate enough to at least let you alter your behavior so that you prevent some of the things we're talking about.
Yep, I totally agree. It is one of the beauties of technology, really, really help giving insight into our habits.
So let's get into another part of insulin resistance, which is kind of the heart of your book, the heart of how we connected. We met at a keto conference, a low carb conference, and it's kind of low carb diets. And it seems to me, and I've been at this game for a very long time, over 15 years, I've been talking about low carb till I'm blue in the face. And I get to talk to people like yourself, but it seems to me we have progressed in the culture that people generally recognize that sugar is bad and they should be eliminating that. They generally recognize that they could be overeating carbohydrates, but it's just an esoteric, we should love them, rather than some prescriptiveness to it. So talk about insulin resistance, because people think, oh, I eat healthy. I don't eat too many carbs. I keep them under 150 grams, Ben. That's good. That's better than everybody else. Why doesn't that prevent this?
Yeah, so it is all relative. And the person would say it's better than the average American. And we would say, yeah, it is, but it's still a far cry of where you need to be. And a lot of the problem with today's culture, eating culture, is that we are told so incessantly to eat a high carbohydrate diet and to eat frequently. So let alone with the type 2 diabetic, explicitly, they're told to eat a lot of little meals throughout the day. And that is just the most asinine advice And that all that is a wonderful way to make sure that your insulin is spiked every waking moment of the day. And to get to kind of bring it back to mechanisms of insulin resistance, hyperinsulinemia drives insulin resistance. This should not be debated. I hear that it is debated in some circles, even among informed people, and it should not. There are so many studies from humans to rodents to cells, to cell cultures, to show that if you increase the insulin, even to physiological levels, as has been done in humans, just bump it up higher than normal and keep it there, even in a normal range, you get demonstrably insulin resistant within just days in the case of the human studies. So this is a real phenomenon, and I think it's the main one. Because stress and inflammation, those are a little more abstract, and we can hope to address them, but sometimes someone just has more anxiety than someone else. They just have a more stressful lifestyle at home or at work, or an autoimmunity. But the hyperinsulinemia aspect, that is based so heavily on the food we eat. And someone who's eating 150 grams of carbs, that's better than the average person, most certainly, but that is way more than I would say it needs to be, or it doesn't need to be anything. I mean, there's no need for carbohydrates whatsoever, of course, in humans. But if we're talking about the average American who's flirting with insulin resistance with their health, they already have a little hint of it. You know, they have hypertension, which is almost always a sign of insulin resistance, let alone any of the more serious disorders that I mentioned, then that's too much. That is because insulin resistance, another way of looking at it is this is a person who does not metabolize carbohydrates very well. So let's just call it what it is. That is a glucose intolerance. They eat that bagel, and whereas an insulin sensitive person, they eat that bagel, their insulin is up and down in 90 minutes. You know, they clear that glucose out, no problem.
Yeah.
Give that to the insulin resistant person. Now their insulin's up and it stays up for 3 or so hours. And right as it's about to come down, what do? Well, they eat again. And then right as it's about to come down, they bump it up again and bump it up again. And that hyperinsulinemia drives insulin resistance. Those two things are inseparably connected. People want to sometimes invoke the term insulin resistance to refer to what happens on a low carbohydrate diet. I vehemently disagree with that sentiment. It is not accurate. Insulin resistance will always come with hyperinsulinemia. And in this case of chronic insulin resistance, hyperinsulinemia is driving the insulin resistance, and then it's feeding into itself.
And this is why the blood sugar connection that people always bring into this, well, my blood sugar stays completely in the normal range. Well, yeah, that means insulin is doing its job to make sure that it stays in this tightly packed window. We'll talk about glucagon here in a minute, but that's what insulin does. But the degree by which the volume of insulin that has to continue to go higher and higher and higher as your cells become insulin resistant, that's what's going to be damaging in the long run. But that's not what people see. Oh, I pricked my finger, got an 85. That's good, isn't it? Well, I'm like, okay, 85 is good as a glucose level, but what level of insulin did it take to make that 85 happen?
Well said. That's exactly right. And that's one of my main points in this book. It is to help the average person and, yes, even dare I say clinician, to realize that insulin and glucose don't always go together. Sure, if you're an insulin sensitive person, and again, most people aren't particularly great in that regard, they will go together. You eat that bagel, your blood glucose is climbing, insulin will come up, push the glucose back down, then insulin will go back down at a nice rate. However, with chronic insulin resistance, and you said it perfectly, we have separated these two variables. The person has ever more and more insulin because the insulin isn't working as well, but it's enough to keep the glucose in check. So if we're only looking at glucose as the clinical marker, well, then we're flying under the radar. We're seeing that, like you said, someone's got an 85 milligrams per deciliter, and we say, that's great, that's normal. And then the patient may say, well, I read Dr. Bikman's book. Could you measure my insulin? And the clinician would say, we don't need to measure your insulin. Your glucose is normal.
The clinician will say, who's Dr. Bikman?
Oh, yeah, that's right. Yeah. Oh, of course. They'd say, Bikman who? Forget that guy. And then even still would spit on the idea that insulin could be separate. But that's what's happening. Right. Insulin resistance, which precedes type 2 diabetes, is hyperinsulinemia with normal glycemia. And then eventually the body becomes so resistant to its own insulin, Now the glucose starts to climb, and then we detect it as type 2 diabetes.
Right.
But that paradigm not only results in us detecting the disease too late, but it also results in us treating it too poorly. Because we are only looking at it as a glucose problem, we don't care that the insulin's high, and we'd say, well, let's elevate the insulin even higher by giving you medications that force your insulin up, like even including insulin injections. And that does lower the glucose, but it spikes the insulin up even higher than before, so the person gains more weight, and they are significantly more likely to die from heart disease and cancer. So we're treating their glucose, but we're killing them faster.
So Ben, let's go backwards, because you talked about this was progressive. It over time they could have caught it, but by the time it turned into full-blown type 2 diabetes, it was too late. It had already been progressing for years. What are some of those very first signs that people will notice? Is it fasting insulin going up? Is it the development of maybe skin tags on your body? Is it glucose starting to go wonky a little bit? What are those things that people could look for to say, okay, this is the early stages, let me do something now before it gets too bad?
Yeah, excellent question, Jimmy. So there are, I think there's a lot I could address there. One thing I could say that is a little more objective, if a person has had a recent blood test, some of the markers that they would definitely get from that blood test is in their blood lipids. They would have their triglyceride number and their HDL cholesterol number. And so one of the best predictors is that triglyceride to HDL ratio.
Right.
So if someone takes that triglyceride number, divides it by their HDL, and if that divided number is lower than 1.5, yep, so that's a good sign. That is typically a sign that they are insulin sensitive. If it's higher than that number, which it very commonly is, then that's a warning. You're very likely insulin resistant, just because insulin so thoroughly controls triglyceride metabolism in the blood. What's coming from the liver. Insulin really has a chokehold on that process, and thus that ratio, triglycerides to HDL, and insulin alters HDL metabolism too, that can be a pretty good indicator. Now, alternatively, if someone is tracking their blood glucose, if with a glucose meter, let alone a glucometer like a CGM, they can see that if a sign of early stage insulin resistance could be that the insulin release is not commensurate with the glucose load. So someone eats a bagel and insulin overshoots, and so the person has a rebound hypoglycemia. If they go down below where they had been before, not to like a pathological range, I'm not talking like 40 milligrams per deciliter, but if they go down to like 70 and they're normally at 85, then that's a potential concern as well. But other things like hypertension, I said, hypertension is one of the strongest indicators of insulin resistance. And then you'd mentioned the skin, which I appreciate. Skin tags and dark sections of skin, like if someone has a dark, like rough section of skin at that's right, at the neck, at a neck wrinkle or armpits, those are also signs.
What's that necra?
Yeah.
What's it called?
Acanthosis nigricans.
I knew you would know how to say it.
Yeah. Yeah, so it's this darkened kind of rough section of skin.
Yeah, and it's pretty rough looking, and people don't even think about like physiological things like that, or the skin tags, which I have a few on my body, and I'll notice them from time to time, and then they'll disappear.
Yep.
And they'll reappear, and I'm going, I thought I got rid of you people. Like, get out of here.
Yeah,
all the time. Oh, we'll remove skin tags. I'm like, no. I want them to stay there. I want them to fall off naturally.
Yeah, that's right.
Resistance.
Yep, and they will go away.
So, you know what I think is going to be a game changer in the coming years is when we can test insulin at home. Like when that is available, and I've been paying close attention to the biotech stuff for years. I got me a fancy schmancy little BioSense ketone breath meter. There's companies working on this. I guess affordability will be the big thing. But when the blood ketone meters came out, they were ungodly expensive and eventually have come down in price. But man, what a game changer that will be, because people will say, well, my blood sugar stays perfectly fine. I'm okay, test your insulin, postprandial insulin, not just fasting insulin, postprandial. What is happening when you eat X food that you think is healthy? And I see the other day, Dr. Tro put out this tweet. Okay, you want to see how good your doctor is? Test your insulin after eating steak and eggs, and then test your insulin after eating the high carb breakfast that he told you to eat. And now come back and thank me later that I showed you data that you wouldn't have known but for.
Yep. Well said. I completely agree. The moment insulin becomes an at-home test, that will be a huge game changer. And that's part of why I believe our obsession with glucose has lingered as long as it has, even in the context of diabetes, when I'm making the case that it should not be the main marker. It's just so easy to measure. It's just a finger prick. We can get it right there. The doctor can give it to us, or we can get it at home. It's so easy to do. But the problem with measuring insulin, it is a significant barrier. To my knowledge, there is no at-home test that can measure hormones. These at-home tests, especially, that's right. Except some that can maybe be excreted in the urine.
Is that why?
You have to get it out of its red blood cell, because the red blood cell will alter the analysis of so many of these hormones. So when you're measuring insulin, you measure it from the plasma, and that is you just can't do that at home. And moreover, the thing with glucose and ketones, those are nutrients. And so it pulls onto a little blood stick in the glucose or ketone meter. And then there's enzymes that will physically just break down, metabolize the glucose or the ketone, and that will give a little electrical charge. And now we can quantify that charge and give a number of glucose and ketone levels. But with a hormone, you can't metabolize a hormone. There's no enzyme you can put on the end of a little stick that will metabolize insulin. Insulin is just a small little peptide hormone. There's no breakdown of it. There's no oxidation of it like there is glucose and ketones. So there are significant hurdles to getting an at-home insulin test. Now, I believe I saw Dom D'Agostino measuring one that would give a color indicator, like it would sense the insulin amount and bind it, and it gives some kind of color that would help you get some idea of a range. But I believe it's just totally subjective. Like you measure it and then you measure it again and now it's higher or lower. It's not actually an objective number to tell you what your insulin is. I'm sure we will get there, given how clever people are. We will have one eventually, but I don't think we're that close.
Well, I'm optimistic that within the next 10 years, there will be a prototype that will be out there. And I guess in the realm of research, 10 years is not that long. So.
No, I agree. I think 10 years is very likely. But I see people who are waiting for it in the next year, don't hold your breath.
No, not this next year. No. And coronavirus has definitely delayed everything along that realm. So, but that could be a game changer, because we do talk about hyperinsulinemia. At least we're talking about it more and more. Yourself, I know Amy Berger's been talking quite a bit about it in her work, and getting away from the glucose model. And guys, don't misunderstand us. Glucose is still a valid marker. It's still kind of showing you things are going on, especially in the context of postprandial, which, by the way, you're wearing a CGM. Do you have your reader close by? You could show us.
Yeah, I do. Let's see where I am. So I'm doing this. There's a company called Levels, and they reached out to me and just said, "Hey, do you want to play around with our device?" And I said, "Yeah, you bet." So it's really fun. Not to give them a plug. I mean, I can give them a plug just because it's not like I'm making anything from them. But what's cool about it is that they give you a metabolic score based on what you're eating. And for example, if I go back this morning, I had a shake that my brothers and I make, and yeah, there you go. So, yep, excellent. So anyone who's curious, go to Get Health, GETHLTH, and look it up. In fact, for Jimmy's listeners, if you want 10% off, enter code KHMD, and you can get some. But what's interesting is it gives you a score. So every time I take the shake, I get a 9 or a 10, because it looks at I indicate it and it says, oh yeah, you had a little or nothing. It's just, this was a good food. And so it gives you this kind of metabolic flexibility score. And the nice thing is the shake every time it's a 9 or a 10. In fact, I find it's a 9 when I take it in the morning. I think just because of the variability that we have when we wake up in the morning, but it's always a 10 if I take it for lunch. But compare that with other shakes, like as I'm doing, like Huel or Kachava, and it's not. I get like a 5 or 6. So it's there's something to be said for nourishing the body and avoiding glucose spikes and subsequent insulin spikes. So yeah, it's fun. I really enjoy being able to kind of play around with the CGM, and I think they're game changers because it lets people know, well, my doctor told me to eat whole grains. And then they see, oh, wait, I had a bagel or 2 pieces of whole grain bread, and oh my goodness, my glucose really spiked. But if I have 2 eggs and cheese and bacon, a whole meal, my glucose doesn't move at all. That becomes really telling. And I think the sooner in the US, the sooner we make it so that people can get CGMs without having a doctor have to give it to them, like so many other countries. I don't know why there's the gatekeeper in the US. We just get these into pharmacies and let people go get them like you can in Singapore and other countries. The sooner we allow that to happen, the better we're going to be.
I would so love that. Of course, I've been thinking the same thing about ketone meters. To get those as well. Very, very difficult to get them in a store. You just can't. Online you can. But yeah, the CGMs, you have to have a medical write-off. And I'm going, that doesn't make sense. You've got blood glucose monitors down at the pharmacy right now. How is this thing any different than a glucose monitor?
I totally agree. Absolutely, 100%. And Jimmy, you mentioning a ketone meter makes me think when I spoke to these guys at Levels, I just asked what the technology is and where they're hoping to go. And what I'm hoping is that someday this teeny little, little patch, it will, in this, I will say Levels is using the Freestyle Libre.
Right.
Just so people know. So Levels isn't making its own. Levels just a software app that takes the data that we get from the CGM. But I imagine the day when a CGM will also be giving constant ketone reading, and this one is a little unexpected that I'd say it, but lactate as well, to measure lactate. And people would think, well, lactate's only relevant for athletics. Not so. Lactate is an energy in the body. We use it. We actually burn lactate. It goes right like ketones. It can get pulled into the mitochondria and burned for energy. What's interesting about lactate is that it can be an early indicator of progression towards type 2 diabetes because type 2 diabetics don't metabolize lactate as well as non-diabetics. And so if lactate is starting to accumulate over time, it could be flagged as a warning for type 2 diabetes.
Right. All right, Ben, I'm going to throw something. I did an experiment recently while I was wearing a CGM, and I've asked Ed Naiman about this. I've asked Kate Shanahan about this. They said, go ask Ben Bikman. So I did an experiment. Let me set it up for the people. Some people that listen to my show or watch it on YouTube or have already heard this. But I decided, because last year I was doing all kinds of tests with Dr. John Lemansky on my Keto Hacking MD podcast I used to do, which you were a guest on before. And so I was like, okay, let's eat a pound of chicken breast because I wanted to take away the element of fat being a confounding variable. I wanted to test just eating protein, a big bolus of protein. I want to say it was 250 grams plus of protein. It was significant protein, just to kind of see what would that do. Now, my results last year, I had a slight rise and then got into hypoglycemia, felt bad, and then blah. It was just bad. So I'm like, okay, let me try to replicate it. It's been a year since then. Let's see what happens. So I sit on this couch over here and I eat the pound of chicken breast, and I tested beforehand. It was 82 blood sugar, really good.
Yep.
And so I did it 15-minute intervals for the next 2 hours was the plan. So at 15 minutes, it was up to 85. Okay. At 30 minutes, it was up to 87. All right. 45 minutes, I'm starving. I am airy-headed. I'm just starting to get lightheaded. I actually had to lean back in the chair. I was so hypoglycemic, basically. I test my blood sugar at 45 minutes. It was already down into the 70s, like up It eventually got down into the low 70s, down to upper 60s by 2 hours postprandial. And I'm like, I can't stop now. I've got to see when it comes back to baseline.
Yeah.
I was feeling like crap. Like, I'm like, things I do for science. So 2.5 hours, it finally got back to 78. I'm like, that's close enough to baseline. I'm ending it. I came in here, I ate some eggs with butter, and I felt better within like 10, 15 minutes. But I obviously had something going on.
Mm-hmm.
No carbohydrates in there. So there couldn't have been a great insulin response from the carbs because there was none.
Yeah.
I also didn't get the blunting effect of the glucose effects that would come from eating that big, large amount of protein. Insulin powered it down.
Obviously.
But my question for you is, do I have an inhibition of the glucagon, which is supposed to help keep that tight range? Insulin and glucagon are supposed to be the yin and yang to keep you at a healthy level so you don't experience that. What happened?
Yeah, geez, that's great. So a lot of thoughts are coming to mind. This isn't you, and I say this because you fast so much. There are people who fast and start to feel horrific, but you fast often and you feel fine. So there's a situation called glucagon resistance. Isn't that crazy to be invoking resistance with glucagon? But it is real. And in glucagon resistance, the people fast and feel like hell because you don't have that glucagon climbing to help maintain blood glucose, let alone to help stimulate the production of ketones. But again, that can't be the case for you because you fast and you thrive in it. So that immediately tosses out the glucagon resistance idea. And mind you, glucagon resistance is often, if someone's wondering about it, it's thought to be a result of chronic liver problems. Like if someone's had bad hepatitis infections, that can lead to glucagon resistance.
Fatty liver.
Fatty liver would very likely be one too. So let's toss that idea out. It's not glucagon resistance. So what was it in that case where the insulin and glucagon didn't go up together? In fact, I do think, Jimmy, what you have there is reflective of a problem of modern eating, and even, dare I say, a problem of our modern obsession with protein. We're not meant to eat protein without fat. And I think that the insulin spike that you probably got from that protein alone, that huge load of protein, was substantial enough to result in that kind of postprandial hypoglycemia. But I say that because if someone looks at our ancestral eating, someone would say, well, we always ate chicken. No, we didn't. 100 years ago, we ate almost no chicken. We would keep chickens for their eggs. And it was only our modern fear of fat that led to us eating so much chicken. We ate beef, we ate pork, we ate eggs. And I don't think it's an accident that the best protein sources come with fat. And I mean dairy, eggs, and meat, not chicken meat. And I'm not saying we shouldn't eat chicken, but I'm saying it's not meant. I don't think that's an ancestral food for humans, as crazy as that sounds. We didn't eat chickens. And I don't think our ancestors would have sought to eat them simply because they didn't have fat. And mankind, humans, we are fat hunters, as this Israeli scientist has shown. I think Mickey Ben-Dori, I think his name, or Ben-Dor, I wish I could remember his name. But he has a very compelling article called Man the Fat Hunter. And just looking at through human evolution, our seeking fatty meat as we hunt. So, yeah, I think that I bet you just had an inflated insulin response to that much protein. But if you had coupled it with fat, like an egg or with some cheese or whatever, it would have mitigated it, and it probably wouldn't have happened.
Well, and when I ate that meal afterwards, that was 8 eggs from my backyard chickens cooked in grass-fed butter with some cheese.
Awesome.
It ameliorated the hunger and the feeling bad within 10 minutes.
Yeah, and in fact, that is part of the problem as we sort of push protein ever higher. And don't get me wrong, I'm a huge advocate of protein, but I think that protein should be consumed as dare I say, as God intended, which is protein comes with fat. And I think that's how it's supposed to come. But when we focus solely on the protein, that is not satisfying. And so if we're chasing protein at the expense of things like fat, I don't think that's natural. I don't think that's sustainable. Like you experienced, I don't think it's going to satisfy someone, and they will get hungry. And that, indeed, not to make too much of a plug, but with our health code, Complete Meal Shake, we wanted to match that 1-to-1 protein to fat. Yeah, it was a 1-to-1 by mass. And even that helps protein work better. There are clinical studies to show that protein alone will have an anabolic effect at muscle. But then if you add protein with an equal amount of fat, 1-to-1 by mass, it is a significantly more anabolic effect at muscle than the protein alone. Like I said, it's like God knew what he was doing when he gave humans these best sources of protein, and they are the best. These animal sources of protein, they come with fat. There's a reason. Let's eat it that way.
Well, and when you say 1-to-1 ratio, that's from an actual gram perspective.
Mass.
You look calorically, that's about 2/3 fat and 1/3 protein with minimal carbohydrate.
Yep, it's typically, from what I know, it's about 70-30 if
Right.
you look at the caloric breakdown. And those are great ratios for me. I'm good with that. But just the simplest way is looking at it by mass. That's a beautiful way to go.
So I did not test insulin when I did my test here because coronavirus has everything shut down. But when I did the test last year, I actually sat in a LabCorp parking lot, went and got my insulin tested, came back out, ate the chicken, sat there 45 minutes in, got hypoglycemic. I kind of held out. I was trying to go wait for 2 hours postprandial. I couldn't make it. 1 hour and 25 minutes. I'm like, I got to go in there or I'm going to pass out. And I walk in, they're like, are you okay, sir? And I get it tested. And sure enough, my insulin had risen over 10 points, which it was 11 at when I started.
Yeah. Yeah.
And it was around 23.
Yeah. So doubled. Yeah.
So it doubled. And of course, I've also heard that chicken, the amino acids specifically in chicken, are a lot more insulinogenic than they would be in, say, beef. Now, I've had 2 filet mignons before that adds up to a pound worth of that meat, and I didn't have any problems with that.
Yeah.
It's a very lean source of protein as well. So I wonder if there's something specific about chicken, and it's interesting you say it's not an ancestral food. I've literally never heard that before. But it makes sense in that context.
Now, and I don't want to speak, lest someone think I say that with too great of authority. I'm not an anthropologist, so I should be careful saying that. But if we look at the data that Christopher Ramsden from the NIH put together, he looked at sources of meat and fat. And you can see the trends over the last 100 years where chicken was the lowest consumed of all the meats in our diet. It was quite low, the lowest of all meats. And now it is the highest of all meats in the diet. And it's because of our fear of fat. And I'll tell you, as a dad, if we do have chicken in my family, I make sure I put butter on it. But even more, I try to have the family eat beef. I believe beef is much better for us. I want my kids to get that iron and those fats from the beef more than I care about the protein from the chicken.
Yeah, it's so funny how fat phobia has literally changed everything about how we live and eat. It's just,
oh yeah,
how many people eat grains today because they were told they were healthy for them, not because they actually wanted it, not because they wake up and crave cereal. Well, they may now because they're addicted to it. But when they first started eating it, well, I know I'm supposed to eat shredded wheat, and so I'm going to sit here and put this in my mouth. Whereas if you hadn't have been told that, would you have ever put that in your mouth? Ancestrally, not a chance.
Not a chance. Well, not a chance because we just wouldn't have had it ancestrally. But yeah, it's in fact, I like what you said there, Jimmy. When people, what I really always want to make sure people understand from my perspective is that the solutions to addressing insulin resistance are simple. Simple. I mean, I really do believe you could almost stop at one single variable, and that is control carbs. I mean, really, it is a simple idea, but that doesn't mean it's easy because, like you pointed out, when we start talking about carbs, We are now talking about addictions. These are people that they can hear that idea and it will make all the sense in the world. But you get to that 8 p.m. every night and common sense goes out the window, and now it's the time for cravings and addictions. And it just takes an almost impossible amount of willpower to get through. Even for me, in the evenings, and I start to feel cravings, the way I can get through them is I just don't have it in the house. We don't eat cereal in my home. The very rare times when we have cereal for the kids as a treat, that cereal box in the evening, it is just calling to me. It's calling to me. If it's a little box of like Frosted Mini Wheats or Life cereal, oh, that's like meth for me. And I'm sure it's because of my college days. We didn't eat cereal growing up in my home either, but you become a college student, that's kind of all you eat. But if I could end every evening with an enormous bowl of cereal, I would, but I will gain weight and I will sleep poorly and it's not worth it. And so I just don't let it in the house.
Wow, you were rich enough to have cereal. I was a ramen noodles kind of guy.
In fact, there's a study on ramen noodles out of South Korea, and the students that ate the most ramen noodles, all calories equal, had the worst insulin resistance. Isn't that funny? That
would explain a lot. Well, I looked at one time, it was like 69 grams of carbohydrate. It's literally all carbs. Things. It's just all carbs. But yeah, and then I'd put American cheese on top. It was bad. So anyway.
That sounds delicious.
Well, it was when they were 10 cents a package and I was a college student. So.
Yeah, cereal was a luxury.
Oh, yeah. It's so expensive now. I even walk down the aisle just to see the health claims they throw on the front package, like fortified with all the essential vitamin D. And you look on the side and it's like 400, IU. And I'm going, that's essential? 400 IU? Go out
It's so silly. It's so silly. All the things they'll advertise, pretending that they're in any way making up for the harm. No, that is a net negative by far.
So what is an element of insulin resistance that you think is either misunderstood or not talked about nearly enough?
Yeah. So I highlighted this earlier, and I just have to say it again because I do think it's not highlighted enough. Insulin resistance is one side of the coin. Hyperinsulinemia is the other. So in that I think helps us not label something as insulin resistance when it's not. And then I mentioned low carbohydrate diet, where some people erroneously throw that term in there, and I'll touch on that now. But just to confirm, insulin resistance will always happen with hyperinsulinemia. I am unaware of any instance where insulin resistance exists, but the hyperinsulinemia isn't there. And that is important because then it lets us use the term insulin resistance correctly. Now, within insulin resistance, most of it is pathological, the clinically relevant, where we worried about the person's, their cognitive health, their hypertension, their fertility. That's all relevant. That's pathological insulin resistance. There are instances of physiological insulin resistance. And I outline that in the book, and I go into the studies there, but it's pregnancy and puberty. In both of those instances, the body has become insulin resistant to fuel an explosive growth. In the teen, of course, it's fueling the growth. Or stimulating it. In the mom, it's stimulating her fat accumulation, and it's stimulating baby's fat accumulation, which happens basically in the last trimester, and that just happens to be when mom is the most insulin resistant. Every woman will become insulin resistant throughout the course of her pregnancy. It is a natural, normal thing. She's supposed to. And it's only when it becomes she becomes so insulin resistant that she can have gestational diabetes. But those aren't necessarily the same, of course. Now, those are the two physiological states of insulin resistance, but even still, it is hyperinsulinemic. Absolutely. Now, why then are people saying a low carb or ketogenic diet causes a state of physiological insulin resistance? Not true. It does not, because insulin levels get exquisitely low. The person does not have hyperinsulinemia. That is not insulin resistance. Now, I will say, I do think that long-term adherence to a ketogenic diet causes a reverse form of metabolic inflexibility. And I don't mean for that to worry people, but I'll elaborate briefly. Metabolic flexibility is this phenomenon where a person can eat a meal of mixed macronutrients, glucose will come up, and they will go to glucose burning mode. And then after a few hours after the meal, they go to into a fasted state. Now they shift over to fat burning. So the ability to very readily shift between these two fuels is metabolic flexibility. Most people that are unhealthy metabolically, they are stuck in glucose burning mode. So they eat a meal, they're glucose burning, they stop eating that meal, hours later, they're still in glucose burning mode. What happens with long-term adherence to a ketogenic diet is the opposite. And that's a better state to be in. If you're stuck in glucose burning mode, you are insulin resistant and all the problems that come with it. If you're stuck in fat burning mode, and I'll elaborate there, that's a healthier state. So I don't mean to imply these two states are comparable with regards to health. But long-term adherence to a ketogenic diet will make it so the body is burning fat so readily that if you suddenly load it with glucose, it has a hard time burning all that glucose. And so the person has become temporarily or acutely glucose intolerant. That is not the same as insulin resistance. So it takes their body a little longer to clear that glucose load just because it's not used to burning glucose. They're kind of metabolically inflexible. They're in fat burning mode, and it takes a little time to get that back up. Now, they can do it. Usually it just takes a day. If you know you've got to take a glucose test or something at a hospital, start getting used to carbs a day or two before again, and you'll pass it with flying colors. It won't be a problem. But it reflects this sort of reverse metabolic inflexibility that happens with long-term ketogenic diet. And I don't think it's a bad thing. It's just something people can be aware of. And perhaps that's justification for people to kind of cycle in carbs from time to time. If they want to deliberately put them in, it would be just to maintain that flexibility. That's fine. I don't know why you'd clinically need to, but that might be a reason to do it.
Well, and some people, Ben, freak out about having a higher blood glucose in the morning, the so-called dawn phenomenon, Shimoji effect, however you want to call it.
Yeah.
And people have said, see, there's the physiologic insulin resistance. And I've heard it said by several people, no, that's not insulin resistance. That's kind of a glucose sparing effect. And
yeah.
There are kind of glucose-dependent functions in the body where you still need glucose. Doesn't mean you need to eat carbohydrate for that. It can happen through gluconeogenesis with protein and fat and blah, blah, blah. So there's ways that can get it. But people freak out when they see that higher level. And almost invariably, I'll tell them, look, you're testing in the morning. Wait a little bit later in the day and test your glucose. Or what's your A1C level?
Mm-hmm.
It was really, truly that elevated and stayed that elevated, it would be reflected in your A1C. And these people almost invariably have an A1C around 5.0. And I go, and why again are you worried about 105 in the morning?
Yeah. Well said, Jimmy. Love it. In fact, I would say if someone's noticing a little higher glucose in the morning, I actually think that is a result of a heightened gluconeogenesis. Because they aren't eating carbs, there is a natural demand for glucose as the brain kind of comes back online, so to speak, and the body gets more active as you start to wake up in the morning. It is natural for glucose to climb. It always happens. I think in the ketogenic state, because you aren't going to eat it, the body has just grown accustomed to saying, all right, well, I need to make more of my own because I know the body we're not going to bring any in. And so I like to say that it's an enhanced gluconeogenic state. But it's always temporary, like you said.
Well, this topic is something I could talk about for hours on end, but you give me 1 hour of pure gold. I really appreciate it. Again, his name, you guys, Dr. Ben Bikman, PhD, and be sure you get the right one, B-E-N.
Yeah.
M-A-N, PhD. Ben learned the other day what it's like to be famous online. I caught a guy trying to clone him, and I'm like, report this guy. And within a couple of minutes, we got him out of there. So
good. I didn't follow up, but yeah, Jimmy, just so everyone knows, Jimmy pings me on Instagram saying, hey, you have a wannabe, a poser, and that was the first time it had ever happened. And I had to ask Jimmy, I don't know what to do about this. Jimmy's, You've been around longer than me in social media, so you knew right how to handle it. I appreciate it very much.
You have now broken into the dark side of being famous.
Yeah.
When they start mimicking you, you know you're doing something right. Also, guys, go check out Why We Get Sick. It's available wherever books are sold, Amazon, everywhere you can get it. Did you do an audiobook for this? Did you read an audiobook?
Well, I didn't read it.
Oh.
No, so I'll say it wasn't an option when we sold the audiobook rights to Audible.
Yeah.
And lest anyone think that means I'm rich. No, people would be so shocked to know how little authors actually, you know this.
Yeah.
As I'm like looking at the numbers, I'm kind of realizing this will never lead to early retirement, like in any possible outcome.
If it wasn't for these 2 books, I wouldn't have made anything at all, hardly, from the rest of the book.
So it's a little discouraging, I'll say, but nevertheless, they gave me options on who to pick for the audiobook, and I picked the guy who had a tempo and style that kind of most matched mine, and frankly, a better voice. I kind of have a bit of a nasally voice. His voice is way better.
Well, it's so funny because I'm a podcaster for a living, because when I started writing books, people are like, where's your book, audiobook, and you reading it? And I'm like, oh, I guess I need to read my own audiobook. So I went to my publisher and I said, my listeners want me to read my own book. They're like, well, we don't have an audiobook division. You want to read it? We're going to have to create a division. So they created a whole division of the publisher, and so I have the first 2 books was Cholesterol Clarity and Keto Clarity. And I've read all my own books. It's not for the faint of heart reading your book. Like, you think you've got pace down and everything. Before concluding this section, I want to include a final contestant for what might be it's harder than it looks, because you like lose energy and you got to take a break and come back. I'm not complaining, though. It was a lot of fun to do that. And people oftentimes say, oh, we just listened to you for 9 hours in our car. And I'm like, I'm sorry.
Yeah. Well, that's how I would feel. I would feel bad. I feel bad for my students who have to hear me for 2 hours in a lecture. So I can't imagine someone going through that. So everyone take my word for it. If you get the audiobook, it's better than it would have been if it were me.
Yeah, at least you don't get, I remember Gary Taubes had his audiobook reader was, and now I'm going to talk. And I'm like,
oh, it's shocking. When I heard some of the voices, there are these like movie, like dramatic voices. And I thought, why would this even be an option? You know, I just went with the guy who just sounded like a normal dude, just better voice than me.
For fiction, that would be fine. But
yes,
for nonfiction, you kind of need a baritone voice. I guess that's what makes my voice good for those things, is I'm a baritone voice and it's a familiar voice. And plus, if it's my writing, they say they hear me talking when they're reading my book. So that's kind of cool too. So
yeah, no kidding.
Well, Ben, you've been such a delight here, and I'm so happy we got you back on the show today.
Thank Jimmy. Hey, really, thanks again. I appreciate it. Really, and I mean it. My first ever podcast right here. And I really have appreciated the exposure you've helped bring what I'm trying to say, and that is look at insulin, for heaven's sakes.
Look at insulin, for heaven's sakes. I love it.